Okay, so morning. All right, we're going to do another ECG analysis today. Thank you for everybody joining us on Zoom. So yeah, today's is actually quite an interesting one. It's a bit more complicated than what we've looked at before, but that doesn't mean that we shouldn't know how to do them. The thing is with ECGs, what I always tell people is just if you can find out what's abnormal, even if you don't know exactly what it is, but it means that you can ask for help at least, instead of just saying, everything's fine because I don't know what it is, so it must be fine. That's not how it works, right? So we're going to go through this one just now, but as usual, we're going to analyze axis, analyze rhythm, we're going to analyze P waves, PR interval, the QRS complexes, QRS after every P, our groupings regular, analyze rate, analyze each zone, all right? So just by having a quick glance at this, you can already see we're going to have a bit of fun today, all right? So what we have is a 41-year-old woman with nausea and vomiting. So what are your first thoughts when you hear that? Let's say you're still walking to see the patient, or you just picked up the file, and the first thing that you see is 41-year-old woman with nausea and vomiting. Are you running to do an ECG? No. What are you running to do? First, 41-year-old woman, still in childbearing age, who's having nausea and vomiting. Yeah, you still want to do pregnancy tests, get a gynae history, see if there's something along those lines. That doesn't mean you shouldn't do an ECG, but it may. So let's say your pregnancy test comes back negative, and when you're looking at the monitor, you see this odd heartbeat. You see on your SATS monitor or your 3-lead monitor, you see bit of a gap, bit of a gap, You just keep on seeing that all the time, And then you kind of wonder to yourself, okay, maybe I should do an ECG. So you end up doing an ECG for her. Okay. So you end up doing the ECG, and this is what comes. But even while you're doing the ECG, you're still thinking of other possibilities. What could the other possibilities be for nausea and vomiting? What causes you to feel nauseous and to vomit besides pregnancy? Very good. Any sort of infection, specifically where in the big toe, the left shoulder? Yes, gastritis specifically. So it could be infection. Anything else that it could be that could lead to nausea and vomiting? Yes, very good. Any sort of intracranial pathology. So not necessarily a concussion, but you could have a space-occupying lesion, an underlying CVA, maybe there is trauma involved, because all of those things could lead to nausea and vomiting. All right. Anything else? Cardiac can also lead to, so you would think of that as well. Generalized sepsis can also lead to nausea and vomiting. Overdoses, medication side effects, things like, not necessarily overdose, but even just medication side effects. So nausea and vomiting is a very non-specific, what you might call it, set of symptoms, So it's quite bad. I always remember when I was in university, we had a friend who thought he could crook the system when we were doing pharmacology. Because one of the big questions in pharmacology is side effects. So for any oral medication, you can put nausea and vomiting. And it's true, because every side effect, the potential of any medication is nausea and vomiting. So whenever he was called upon in class, like, what could be the side effect? It didn't matter. When you were talking about pharmacology, his hand would just shoot up, nausea and vomiting. And eventually one of the profs caught up to him and says, if you say nausea and vomiting one more time, I'm going to fail you immediately. And it was the first time I actually saw him shut up, to be dead honest. But anyway, so now let's have a look at our ECG. All right. So the first thing we're going to have a look at is we're going to have a look at our axis. All right. So we're going to look at leads 1 and AVF. All right. Now in this case, both of them are pointing upwards. So that lets us believe that there should be where would the axis be? Let's draw it out. All right. Oops. Just sorry about that. Okay. Let's just clear that up. All right, so let's draw a little grid for us. All right, so we have this one yellow today. All right, so we remember we have leads 1, so just put a 1 there, and we had lead AVF here. All right, sorry, I'm trying to do my best. All right, so lead 1 is pointing upwards. All right, let's change the color here a little bit to red. So if lead 1 is pointing upwards, that means electricity is moving towards lead 1. Agreed? So we have normal axis, left axis, extreme right and right. Okay. So we know immediately it cannot be this one. Right? It cannot be an extreme right axis. It cannot be a right axis. All right. So it leaves us with only 2 possibilities, a left axis and a normal axis. So to tell us which way, let's look at lead AVF. And which way is lead AVF pointing? Up or down? Up. So here's lead AVF. Which way is electricity moving? Towards it, because electricity is being seen by AVF is moving towards it. Right? So we know that it can't be here. So we've kind of canceled out 3 of the possibilities because we already said it can't be here. So what's the only one that's left over? Normal. All right. So just remember that's how we work with our axis. All right. A quick way to clear that, to work with that. So we know we've got a normal axis. That doesn't mean everything's okay. It's just a starting point. All right. So let's go to the rhythm. So let's look at our P waves. All right. So tell me about the P waves themselves. What do you see? There should be something that you notice. If you just look at the P waves, compare each P wave to the other one. Not really irregular per se, but how do they look? For example, compare this one to this one, just as an example. Just the physical look of it. Does it physically look the same? If you look at this one, it's nice and peaked. And if you look at this one, it's like a bit more, it's got like a quick upslope and then a long downslope. And then if we go to, let's say this one, again, this one is peaked. And this one we see it's got like this weird slope, comes down. This one looks normal. Then you get a kind of abnormal one, another abnormal one. And then we see like those lines in between. So there's something wrong. Our P waves are not normal. Okay. Now the question then becomes, are they regular? So let's have a look and see. So we've got a distance of 1, 2, 3, 4, 6, let's say 7 blocks, right? 1, 2, 3, not regular, right? So it's not a sinus rhythm by any means, right? And in fact, then when we come to this one, we've got a big gap, 1, 2, 3, 4, 6 over 7. And then again, it comes to 1, 2, 3, 4, 5. So we've got this, these atria that are not functioning correctly. That's what, because remember the P wave tells us about the atria. So we've got this atria that's pumping normally sometimes, and then it will have a bit of a gap, and then it pumps again, but it pumps abnormally, then it pumps again, then it pumps abnormally. And then sometimes pumping twice abnormally, sometimes twice not. So this is the type of patient where if you've used our ECG or any ECG machines, you know it's got a rhythm function where it can monitor the rhythm for like 3 or 4 minutes. But ideally, we'd want to do that. We want to monitor this over 3 or 4 minutes. But even on our basic ECG, we can see, listen, something's wrong. There's definitely something wrong here. Number one, they don't look all the same. So that means the atria is struggling in the way that it's functioning. And number two, it's very irregular. All right. So let's look at our PR interval. So if they are irregular, that means we've got to look a bit more deeply at our PR interval as well. So in this one here, we've got 1, 2, 3 blocks. That's normal. This one here, we've got 1, 2, 2.5 blocks. So it's becoming a bit abnormal. 1, 2, 3, 4.5 blocks. So that's a bit long. All right. Then we come to 1, 2, again, just over 3. And then we come again 1, 2. So it's a very irregular rhythm. All right. So here we've got 1, 2, 3, 4.5. So it's not following any particular pattern. It's kind of just coming, going. It will pump normally and it will give its signal off normally. Then it's taking a bit more time. Then it's giving a bit of a short time. So we can see there is something wrong. So even if you don't know what's going on, immediately this should ring some alarm bells because this woman is having nausea and vomiting. So what could be going on? You know, so in other words, it could be a cardiac problem that may be leading to the nausea and vomiting. Right? So that's one thing. Now, of course, this is in conjunction with all of your other parameters, pregnancy test, overall, you know, physical examination. Remember your ECG, you don't see a patient, put on an ECG. This is after your physical examination. So you may already notice something. Right? Let's look at our QRS complexes. Are they narrow or are they wide? They are narrow. Okay. So that means whenever the atrium is functioning, its signal is going to the ventricle. So that means the ventricle and the atrium are connected. All right. And it's not necessarily a hard block because it's getting through quite regularly, you know. That's the thing, all right? Because I know somebody's going to pipe up over here and say, no, this is a Mobitz type 1. This is not a Mobitz type 1. Somebody's going to say it's a Mobitz type 2. It's definitely not a Mobitz type 2, which is why I picked this one, because I know how people think, right? I'm not a psychologist, but I know people love to give answers. Mobitz type 1, because I heard that somewhere. It's not a Mobitz type 1. Okay, all right. Then let's look at does a QRS follow every P? So in other words, is the ventricle contracting after the atrium every single time? So let's have a look, all right? So let's look at our P wave. Is there a P wave and a QRS? Yes. Is there a P wave and a QRS? Yes. Is there a P wave and a QRS? Yes. P wave and a QRS? Yes. P wave and a QRS? Yes. The reason why I'm doing each one is because we have to make sure. P, QRS, P, QRS, P, QRS, P, QRS, P, QRS. So in other words, the atrium is malfunctioning. But whenever it does malfunction, it is still sending its signal through to the ventricle. So that means the ventricle is following the atrium. It's not that there's a hard block between them. So this means the problem is lying where? In the atrium or in the ventricle? In the atrium, very good. So that means there's something going wrong with this atrium, all right? Now let's look at the groupings, all right? So remember, we're trying to see, are the groupings regular? And it doesn't take a rocket scientist to see, no, they're not regular, all right? So let's see, but there is a little pattern that's emerging over here. So you notice we've got 1, 1, 2, 1, 1, 2, 1, 1, 2, 1, right? When you really look at it. So that means we are getting a regular, irregular rhythm. All right, so that's what you call a regular, irregular rhythm. So if you were to put your hand on the pulse, you get dum, to dum, dum, to dum, dum, to dum. It would keep on following that particular pattern. All right. So if we really look at it, what is happening is that we are seeing that there's well, let's have a look. Let me break it down a little bit more. All right. If we were to really break this down, what we would see is that we've got. Can you see these are kind of regularly spaced? Okay, not all the time, but kind of regularly spaced. And then we've got these little ones that come in between. Okay, so that's kind of giving us a clue as to what's going on. I'm not expecting an answer. I'm just giving you an idea. All right. Now the question is this a tachycardia or a bradycardia? That's what a lot of people will wonder. Because technically from here to here, that's not a tachycardia. It's quite normal. But from here to here, it is a tachycardia. So the question always comes, which one do you take? So technically speaking, you count this as a tachycardia, because you count the two narrowest ones, all right? So that's normally how it's taken. But is this patient tachycardic? No. All right, so that's why I say it's a technicality. In technical terms, even your machine would actually work out this one to this one, all right? The two closest peaks. So if we had to work it out, we had about 1, 2, so about 100 is the maximum heart rate. So it's not really a massive tachycardia. So this is not a rate problem. This is a rhythm problem from what we can see. But nevertheless, that doesn't mean we shouldn't look through the rest of the ECG, all right? So we come to the inferior leads, which are leads. I've given you one already. 2, lead 2, which are the ones? AVF and this one, lead 3, all right? So you've got leads 2, 3, and AVF. So what do we see in those leads? Anything abnormal, anything that doesn't strike you as normal? You can pick out any abnormalities, whatever you see. This one looks relatively normal, agree. What about lead 3? Is that how it should look? No, it should look closer to this. So what does it look like? It's inverted. It's got like a QRS that's upside down. But actually, I mean, you could actually argue that this could be a Q wave, an isolated Q wave. So it may mean that there may have been some ischemia sometime, but it's very isolated. So we don't really stress about it. And if you look at lead AVF, we've just got these little small QRS complexes. So there could be a few reasons why this looks like this. Remember, AVF is put on the foot. So it could be a fat foot, you know. It could be it was put too distant or put over a bone or something like that. And that's why it's giving us this abnormal voltage, because all the rest seem to be fine. Okay, we only get worried when all the QRS complexes are small. So this one here, it could just have been a malplacement, you know. And if you see it, you can just go and check. It may have been put directly over the ankle, which doesn't conduct very well. So you put it more on the fleshy part of the foot and take it from there. All right. And then let's look at, well, we'll come back to these two, AVR. That's kind of how AVR should look. All right. Then we look at the septum, V1, V2, and that's quite normal, actually, come to look at it. The only thing we notice here is our T waves, not really that prominent. Okay. And then we come to the anterior part of the heart, V3, V4. It's nothing that abnormal. That's kind of how they should look. The only thing, again, we notice is our T waves. All right. Our T waves are not that prominent. You know, we should be seeing nice T waves. All right. Then we come to V5, V6, which are our lateral leads, V5, V6, and 1 and AVL, which are our high laterals. And that's kind of normal. I mean, that's what they should look like. All right. So we know we're not dealing with an ischemia. We're not dealing with a, you know, an old ischemia or anything like that. What we are dealing with is a rhythm abnormality. Okay, but what can cause rhythm abnormalities? What can make the heart to beat in a weird way? Almost had it. You just mumbled it to your mask. That's the only thing. Very good. Electrolyte abnormalities, 100% correct. And remember, she's got nausea and vomiting as well. So it could be definitely an electrolyte abnormality, that could be causing that, What else can lead to it is direct damage to the heart as well, right? So direct damage to the heart can be from ischemia. It can be from direct trauma, anything that leads to any sort of problem with the heart. Then you get more complex problems, things like channelopathies and what you call myopathies and things like that. So you've got to look at all of those. In the emergency department, you can't, but I'm just saying those are things that you would look at. And then the other thing that can lead to this is also intracranial problems. Because remember, the control of the heart is from the brain, specifically from the midbrain. So could you have something like an intracranial abscess or a space-occupying lesion? Is there raised intracranial pressure? So it kind of gives you an idea that, listen, there may be something in those areas that's causing a problem. Now, how far would you go? You'd first do a blood gas. Let's say your blood gas comes out abnormal. Sodiums are all over the place, calciums are all over the place. Then you know, all right, listen, I've got a problem here. Let me try and treat that first, all right? Or you've got a patient now with a diminished level of consciousness who's also vomiting and now has this abnormal. Then you know, listen, I've got to concentrate more on getting a CT and making sure everything is over there. Patient was involved in an MVA and hit their chest against the steering wheel. Then you know, listen, this is direct trauma. Patient presents also with a history of chest pain. She's very overweight. Then you know, okay, I could be looking at ischemia, all right? So remember, you don't have to diagnose everything of an ECG. An ECG is there to help you. Okay, so any idea what could be happening, or what in ECG terms, and even to the people on Zoom, ECG terms, what would we say is going on over here? Because what we've got is that we've got generally a normal rhythm with these interspersed extra, let's put it like that, extra contractions. So what's happening? We've got an atrium and ventricle that are functioning, but every so often, the atrium kind of kicks in, just like it does here. It kicks in, and then you get another beat in between. So what's that atrium doing? Hey, very good. Well done. The exams will be a breeze. If you can diagnose that as a student, I didn't even know how to pronounce atrium as a student. There you go. Premature atrial contractions. All right. Now, the reason why I picked this one is because it's always one that people get worried about and they start diagnosing some weird things when it comes to premature atrial contractions. All right. Now, we've covered the hows and the whys. Now we're going to have a look just at premature atrial contractions. So there's quite a few reasons why they happen, all right? But the important thing is that you have to consider it in, you have to be able to look for it. And the only way that you can look for it, and the reason why I picked it, is because sometimes you have to spend a few more minutes with an ECG than just having a quick glance. It's kind of like how we sometimes look at an X-ray. We put it up against the board. The answer doesn't jump out at us. We put it down and write NAD. You know what I mean? Because we didn't see something. So sometimes what you've got to do is just spend those few extra minutes and just think it out a little bit and just rationalize it to yourself and think about it in terms of what is actually what you are seeing on the paper and what is physically happening. All right. So let's have a look and see. So we've got, all right, they say sinus rhythm, all right, with frequent premature atrial contractions in a pattern of atrial trigeminy. All right. So what does that mean in simple terms? They are saying it's a sinus rhythm because generally everything else is okay, even though there's a lot of technicalities in this one. We're not going to get into that. So they said frequent premature atrial contractions. So here's your premature atrial contractions happening. With atrial trigeminy, what is atrial trigeminy? Trigeminy means that there are three different types of atrial morphologies. So bigeminy would mean two different types of morphologies. Trigeminy, three different types of morphologies. Do you get others? Yes, but they're not that common. Bigeminis and trigeminis are the most common, all right? So we've kind of picked that up, so it was okay. And then they put the rate as 61, which is fine. Oh, sorry, the wrong one. So because they are taking from there to there, okay? But if you're on your machine, it would reflect as that, okay? Which is fine, that's not a problem, all right? So the rhythm is regularly irregular, which is what we said as well, all right? Because of the occurrence of the PACs. Premature atrial contractions are identified when P waves occur early in the rhythm. So in other words, you saw that we had everything contracting normally there, but in between you would get these that would disturb that rhythm, all right? So that's how you kind of come to it. Now, if you forget this in 3 weeks' time, that's fine. But just as long as you remember something's not right. If you can look at it and say something's not right, you've actually done quite well, all right? The morphology of the P waves are often slightly different to the sinus P waves. It takes a few minutes that you've got to really look at it, right? And the PR interval may be slightly different as well, which is what we found. It was 2, then 4, then 3, and things like that, right? PACs cause the sinus node to reset, leading to a pause in the rhythm before the next sinus beat occurs, all right? So what happens is when you get the premature contraction, so in other words, so we've actually been, these are the premature contractions, sorry about that. So what's happening is that you're getting 2, and then you're having the premature beat, and then it resets to the next one. All right, you get a normal, and then again you get the premature. All right, and then you go. So my apologies for that. I'm also learning as we go along. You know, sometimes I do these things a month and a half in advance, and I've forgotten them by the time we get here. I should revise them the night before, but I don't. So what are the causes? All right, so anxiety can happen. Sympathomimetics. Any sympathomimetics you know? Cocaine, caffeine, right? We're not saying everybody's a cocaine addict, but I'm just giving you examples, all right? Beta agonists, right? Any sort of beta agonist? Any beta agonists that you know? Palms, things like that, right? Hypokalemia, hypomagnesemia, like we said, we look at those sort of things. Digoxin toxicity. Now, digoxin toxicity is not as common nowadays because we've kind of moved away from the use of digoxin, but you still get a lot of patients on it, so it can happen. Right? And digoxin toxicity is not diagnosed only on ECG. There's a few other things, but that's a whole thing on its own. And myocardial ischemia. So it doesn't mean that you haven't seen ST elevations and depression that you say, okay, everything else is going on. Right? So clinical significance, they are normal electrophysiological phenomena, not usually requiring investigation or treatment, right? Frequent PACs may cause palpitations and ascent of the heart skipping a beat, right? In patients with underlying predispositions, such as such, PAC may be the trigger for an onset of a So in other words, what it's saying is that we've got a patient with nausea and vomiting, and these are the possible things that could be going on. So in other words, if you have it, you quickly Google causes of PACs, and you go down the list. And you say, listen, are you taking any of these things? Are you on any of these things? And then you try and marry it to the nausea and vomiting. So in other words, the nausea and vomiting may not be related to these at all. Could be something completely out from that. Agreed. Could just be simple food poisoning or something like that. But what they're trying to point out is that you still need to look at it. Because what if it is hypokalemia? You need to treat it, you know. And hypokalemia has a wide set of symptoms. You know, you could have a patient who is in metabolic alkalosis as well with hypokalemia. She's been vomiting excessively, you know, so it gives you a clue as to what you need to do, all right? So these are the things. So these are the same features that we kind of talked about, but we'll just go them in a bit more detail just so that you guys can see. But I can promise you, even I won't remember this in a week's time, right? But just so that you know, an abnormal P wave is followed by a QRS complex, which is what we saw. The P wave typically has a different morphology and access to the sinus P waves. We didn't see a difference in the axis, but that's fine. The abnormal P wave may be hidden in the preceding T wave, producing a peaked or camelump appearance. This is not appreciated. The PAC may be mistaken for a premature junctional contraction. That's if you're a cardiologist. PACs are rising close to the AV node. Listen, when you guys have a chance to read through this, right? I'll leave it up on the screen for a few minutes. The truth be told, all of these things are very lovely to guys and know, but in an emergency department, it doesn't really help us because we're not going to go that in-depth into the patient, right? But these are lovely things. If you have a chance, especially if you're watching the video later, pause this, read through it and go through it. I fall asleep when I read all of these things because we never actually end up looking at all of them, right? We kind of look at the bigger picture, and then which is the joy of the emergency department. You don't have to go into too much detail. Whereas a physician needs to know 30 causes of something, I need to know 3 and say, right, it's one of these 3, you take over and catch on, right? But at the end of the day, the important thing is that you can recognize that something is wrong. And I always maintain that the most important thing is pick up that something is wrong. If you come to a diagnosis and you can't remember all the causes, look it up. It's the beauty of the technology that we have today. You can just look it up. You don't have to memorize textbooks. You've got all your textbooks sitting in your pocket, available for you. You know? So that's what you should try and do. So, right, classifications. So you can have unifocal, right, single ectopic focus. Each PAC is identical, multifocal arising from 2 or more ectopic foci. Which one do you think we had? Which one do you think we had? I'm kind of pointing. Multifocal. So we had multifocal, right? And then they occur in repeating patterns. Bigeminy, which means every other beat. Trigeminy, every 3rd beat, which is what we had. And then trigeminy also refers to the morphology that you can have as well. Quadrigeminy, couplet, 2 consecutive triplets. So these are all more important for the physicians and the cardiologists to take. Right? But just to give you some examples of how in-depth you can go on these topics.
Yes, I was like, yeah.
Week of lectures on their own. So we're not becoming cardiologists, so we're not going to stress too much about it. So that's the end of it.
Sister Beans didn't enjoy the nice but
not about the last 2 slides,
in,
that's
the
just
casual
boring.
tools already functional.
But everything else, yeah.
I do all my phone with this.
No problem.
I don't know what other tools.
Yeah, you can see it
the
here. Look,
females.
right? If you come to that one, can you see that? All right, but sometimes it's not as pronounced. It may come directly off from there, so it produces more of a chemical. And in fact, that's one of the signs of hypokalemia as well, right? So it's
So guys,
also a chemical hump, U wave, things like that. But in this case, it wouldn't really be like that because this is a definitive P wave. In hypokalemia, you get that, and still a P wave after that, you know. So that's one of the things you'll see. But it has almost like a camel hump appearance, right? So I always maintain the important thing is whatever you can get right, get right. Whatever you can't recognize, it's not an issue, but make sure that you pick up abnormalities. And if you're not sure of the diagnosis, ask. The worst thing that you can do is just say, I'm not sure. You are fine. Go home, right? Because there may be something serious going on, right? And the only way you can know abnormal is to know normal. Okay. All right. If there's no more questions, I have to get back to work today, and you guys also have to get to your units. Just want to thank everybody on Zoom. We'll post the video later. If there's any questions after, you're welcome to still message me, and we can go through it. Okay. All right. Thanks a lot, everybody. Sorry for the late start this morning. And on Wednesday, we'll be having one of our last ultrasound meetings. Thanks. Bye.